the other emergencies that you and DoD have had to respond to, and if you could, give us a sense of the scale of this. I believe it was the U.S. and Singaporean military responding to the tsunami in Indonesia, where the scale was quite large in terms of mobilization of troops, moving quickly. How has this been different or the same?
Well, I think it's different because we have a lot of experience responding to disasters. Okay, it could be Haiti, the tsunami, but the kinds of help that you need for that is not the same kind of help that you need to combat Ebola. The whole issue or the whole experience related to Ebola is new to us, was new to us. We did not have any capability. Well, that's not exactly true. In the research community, we did have some capability, and that's where our trainers are coming from and things like that. But as far as products that we could just ship over and start using, no, we had no experience in that. So that was part of our learning curve that we had to go through. A good example is the Phoenix Air capability that brought back the doctors or the individuals who were exposed to either Emory or NIH or to the University of Nebraska. So the Phoenix Air has a capability with a module in it to handle somebody who is offloading large volumes of bodily fluids. Okay, we have nothing like that. Our packages are all designed for respiratory issues. Okay, so we had capabilities for that, but it was totally inadequate and unsuited for Ebola. So we are now in the quick catch-up mode of trying to develop pods that can actually travel on our aircraft that will provide the same capability that the Phoenix Air has. So that's really the difference is we were entering a new area of that we had no experience in.
Adam, while we have you on the line, you mentioned working with universities and ministries. Could you tell us a little bit whether or not International Medical Corps or through your university, did you have memorandums of understandings in place, where you were able to move more quickly in that environment? Or how did that work for you?
Well, so International Medical Corps had set up a memorandum of understanding with Cuttington University in Liberia. So Cuttington University is actually one of two nursing schools in the country, and like all universities, as well as all secondary and primary schools, it was shut down when Ebola started. And campus was basically being unused. So International Medical Corps met with the campus leadership and developed a plan basically to take over operations of the university, to run the generator, to pay for the cafeteria to run, et cetera, and in return housed its own staff working at the Ebola treatment unit, which was very nearby, and then also turned its classroom space and other space into a new training center for humanitarian responders, both local and international. So that was set up not in advance, but it was set up, in the weeks before we opened up our Ebola treatment unit. But those local partnerships are incredibly important because all of the infrastructure that's there is going to be local, and so taking advantage of it is going to be incredibly important.
Thank you, Adam. Joe, when you said that you have worked with a lot of competitors, I think that's nice to hear, and that you've made it work. Sometimes we do struggle with that, even in global health. Could you tell us a little bit more about the mechanisms. Do you put some of your leadership on boards of other companies? Do you provide a pool of funding from all these competitors that is used in a neutral fashion during an emergency? Could you give us a little more detail?
Yeah.
Thank you.
Predominantly, we've got a core of responders between the four companies that I mentioned, of over 100 people with specific logistics skill sets for transportation, warehousing, or air operations. And they've responded to over a dozen natural disasters over the last 6-7 years. Most recently in the Philippines, we deployed UPS or Oliver Bartolo out of the Philippines, and he led a team of 21 representatives from those companies that deployed and helped initially provide clarity to the customs regulations of that country as all these supplies started to come in. And as anyone knows, that some small little airport in the middle of nowhere becomes the center of the universe after a disaster. You mentioned the capacity of the airports in West Africa to be able to handle these supplies. For instance, the WFP is now asking if there are flights that go in to please notify them so they can manage the airport operation, so that you don't have 5 flights and have this disaster within a disaster of all these supplies taking up the air ramp capacity. But we work very collaboratively. Again, our organizations provide what they can. We have guidelines of when we deploy. Our support for the Ebola crisis is a sort of a unofficial deployment because we have criteria that says, A, it has to be a natural disaster, B, it has to affect over 500,000, and we have all these criterias that allow us to navigate. And I'll tell you, it wasn't easy. It took a couple of years to negotiate the guidelines and build trust, but I'll tell you that the people that we work with at those organizations are like partners. It's hard to say, our competitor is a partner, but they are truly invested in what we are to help people who've been impacted by these disasters.
Have any of the three of you worked with faith-based organizations as you deal with different behaviors that have a religious origin, or has that been an issue on the ground? And Adam, I'll include you as part of the three here to possibly answer that. Who would like to answer that first?
UPS works with many faith-based organizations. We work with the National Voluntary Organizations Active in Disaster, made up of 50 to 70 faith-based organizations. We work with organizations like the Salvation Army. We're currently working with them in the Philippines. We fund them. They're helping to replant the coconut trees that were destroyed. We work with many of the faith-based organizations, and it has been really no issue with us.
From the Department of Defense perspective, if we step out of the Ebola environment, we have lots of strategic partnerships. I couldn't tell you how many might actually be faith-based. But as far as the response to the Ebola crisis, our parameters were pretty restricted as to what we would be expected to do and what we would be required to do. Now we're using local labor in most all cases that where we can. Whether they're faith-based or not, I couldn't tell you.
As you know, in all humanitarian emergencies, 90% of the responders are local, and even most of the humanitarian organizations that are coming in, the big international NGOs, are going to be partnering with local community-based organizations in order to set up their operations. So that's certainly true for International Medical Corps as well. We've partnered in all contexts with community-based organizations, including in the context of Liberia. And in most cases, those community-based organizations are faith-based of some sort. So we definitely do end up working with the faith-based community, perhaps not specifically, but just as part of working with local community groups and outreach to local communities.
We have an audience here that's probably pretty anxious to ask you a lot of questions in our last last 30 minutes together. So I'd like to open it up. Please, Dick. And I can see this part of the room, but I think, Rachel, you'll help me if there are questions over here also. And so, Dick, would you want to go first, and then we'll follow?
Okay, thanks, Louise, and all on the panel, and Adam especially. We appreciate your and Tim Flanagan's and so many others' tremendous work in this area. I'm Dick Garant at the University of Virginia in Global Health and Infectious Diseases. I want to ask Adam, if I could, the thing that's probably farthest from your mind right now, especially as such an effective emergency room expert physician, and that is to extend the incredible impact that you are having and have been having now for several weeks. And when you think about getting 70 liters of water per staff member available that are safe, the infection control, the epidemiologic surveillance, the diagnostic laboratory capabilities. You may have started to answer this, Adam, when you were answering Louise's question a few minutes ago, but what might be the ways that this extraordinary effort could have the lasting impact that it certainly might have, and obviously it's most desperately poor countries on the planet, and partly also how might this private partnership, public-private partnership group help extend the impact of what you're doing?
Thank you for that question. And I think, even in the midst of this epidemic and this crisis, it is important to think about how we build resilience for the future. I mean, certainly one thing is clear is we are learning far more about Ebola virus disease than had ever been known previously. And so a lot of the knowledge gained will be helpful in terms of responding not just to Ebola outbreaks, but other types of outbreaks in the future. I think the most important thing going forward, though, is health system strengthening, and specifically health system strengthening around what health systems in African countries do, I think, the poorest, which is triage and surveillance. So I actually was in Addis Ababa for the African Federation of Emergency Medicine conference last week, and I gave a talk about Ebola. And, the one thing I've learned about Ebola is that more so than being a disease of individuals, it's really a disease of healthcare systems. And it's the entire healthcare system that is affected by even a few cases, and the entire healthcare system that collapses. And it's those healthcare systems that are weakest that are the ones that are most vulnerable. And so in this conference, I was talking a lot to directors of emergency departments from Kenya and Mali and Malawi and Ethiopia and all over sub-Saharan Africa about how they can set up triage systems and other systems in place to identify cases of Ebola early, because it's identifying it early and being able to quickly quarantine and treat those individuals that's going to stop it from spreading into these countries. And I mean, for me now, that's still my greatest fear, is that this virus will spread beyond West Africa to other countries in sub-Saharan Africa, which have healthcare systems that are just as weak as that in Liberia and Sierra Leone. And the more we can do now to strengthen those health systems and immunize them in a way, you could say, against an outbreak in their country, the more we can do to stop this localized epidemic from becoming a pandemic, really.
Thanks very much. I really have nothing but admiration for the last two speakers. Not to say I'm not admiring what Adam has said, but how you handle the logistics of getting stuff from here to there. I mean, it is absolutely tremendous. I want to underscore the point you made about sending cash. The do-gooders sending cash and not green. Experience of mine in Central America when we had several pairs of green high heel shoes someone wanted to send. That's all they had to contribute. But the real question I have, though, is having got the material there, what role did you have in triaging of the material itself, helping it to get from place A to place B, or whether your job was really to get it from here there? Because often getting the material out from the place of its destination is often as important as getting it there.
Well, that's definitely one of the challenges because we all know last mile delivery is the holy grail of humanitarian relief, right? Many people can get things to the airport, but beyond the airport. In Haiti, we saw getting it 2 miles from the airport was the challenge because you needed a military escort to get it to where it needed to be. It's challenging. We operate in all these countries. In some, we have what we call brown operations, and others, we have local agents. So we have worked with local agents in country to make sure that our supplies that are delivered get to where they are. But many times we do rely on those in-country NGOs we make sure before we ship something that we're shipping with somebody who has credible relationships with organizations. For instance, MedShare is one of our partners who delivers a lot of hospital supplies and the medical supplies, and they've worked with over 30 hospitals and organizations in country so that they make sure on the destination end that these supplies, when they get to the port, that we know and are comfortable they're not going to sit there and create a problem just sitting at the port and not getting to where they need to be. So we make sure we vet our organizations and our partners so that they can move them or we can move them if we have the capacity. Right now we're working with the CDC Foundation to bring in 70 trucks. 70 Toyota trucks are going on 6 charters over the next couple of weeks. That should increase capacity to reach these extended areas. I know that there's an effort to get out to the homes, try to bring these home protection kits, the disinfectants, because we know that some of the people aren't coming to the clinics that need to come get care. But again, in any disaster situation, that is the biggest challenge, that last mile delivery.
If I can tag on to that, we knew when we couldn't set up an airhead in Liberia that we chose Senegal as the place that we had the problem to get products after they landed in Senegal out to the field locations. And so in our case, we're actually bringing our own resources to do that. Clearly, we will hire locals to augment, but as part of our logistics support tail will be that trip from Senegal to wherever it needs to be within the receiving countries.
Elaine, and then Pat, and then we will.
Hi, Elaine Gibbons from Path, and this is a question for all the panel, but might be best directed to Adam. I wonder, could you comment on the Firestone example in Liberia, how successful they were with education of the local community and mobilizing, particularly after the closing of the schools?
I'm sorry, I didn't catch the whole question, though. Which example in Liberia?
The Firestone?
Okay.
The company response there that was touted as being, if not unique, certainly unusual and quite successful in managing the burden of the disease in their local community?
Right. So I don't have a tremendous amount of knowledge about Firestone and its operations. I do know that one of the benefits that they had was that they were already there before the epidemic started, and they've been, managing clinics and facilities for their employees for, decades, perhaps over a century in Liberia. And so they know the local context very well. They have these clinics that are set up that are well-staffed and well-funded through the Firestone Corporation. And so it was perhaps easier for them. They had the capacity to quickly identify cases that came in and to respond to them appropriately. I think the bigger challenge kind of outside of that network is that you had a very weak public health system in Liberia without good access to care, especially in rural areas for people. And that health system was even more incapacitated by the first cases of Ebola because many of the nurses and doctors working in it became sick, and then as they became sick, their colleagues stopped coming to work. And so that made it very difficult to get on top of the epidemic early on and allowed it to really spread in communities quickly. So can't speak too much more directly about the Firestone example, but I think, having a well-organized and well-funded and orchestrated system in place before, an epidemic occurs definitely is going to help in terms of preventing its spread.
Pat?
Thank you. When Mr. Sipos began, he talked about the first thing DoD did was put in some command and control infrastructure. And I'm just wondering if the three panelists could speak a little bit about the overall command and control infrastructure. Do you perceive that it's functioning well? Who's really in charge? Who tells you what to do? Do you feel that these many moving parts are all coordinated? I find it kind of a miracle the way things are working, and I'm just wondering what's the glue holding it all together? And then the other thing I would like you to opine on is what are some of the unsolved problems right now? Are there elements of the response that perhaps could be addressed by public-private partnerships that haven't yet been invented? Are there sectors that should be involved that might want to be involved but just don't know how to get involved and how to integrate? Thank you.
Well, I'll start and take on the question of how I think the organization is working. Clearly, from the Department of Defense's perspective, we have a single point of contact in the DART team, the State Department team. All requests will come through them. So we cooperate with the government of Liberia, but any request for us to do anything different than what we've already been tasked to do comes from that. I can't talk to the organization structure on the other side of the DART team, only on the DoD side, and it seems to be working very well.
Well, again, our approach is to work at the direction and help fill the gaps of our strategic partners. So, again, we're working at the direction of the UNICEF's and the World Food Program and the logistics cluster. So we know for us, they're the coordination point. So they provide us with what the gaps are, and essentially it's an opportunity for us to fill those gaps if we can. And when we can't, we simply have to tell them either we don't have the capacity to do it, and we're upfront and very direct with them when we can't. And that could be a challenge too. I mean, the corporate sector, the private sector, I think they're very engaged in corporate social responsibility, but there is to some extent a limit to how much philanthropy that is out there. And I think one of the challenges sometimes is this perception in the humanitarian sector that the private sector has these ulterior motives, that they're in it for profit. And I don't agree with that. I think, but that there needs to be an understanding that in order to do more or to go that extra mile to meet the needs that are currently out there, there needs to be some understanding that organizations want to do it, but they have to cover their costs in some ways. I think that's a challenge that we face all the time in natural disasters. We've been working domestically with the states and FEMA trying to understand, this is what we do with our NGO partners, and they all know what we're going to do, but we think there's more that we could do to help these communities become more, recover faster, but we haven't been able to find that central coordination point, that command and control to go, we're willing to do more, whether it's transportation, logistics, but who do we talk to do that? And can we do it so that we can just cover our costs? Because we can think we can help. But that's sometimes a gap. And again, that command and control is all over the place, whether you're talking about local, state, federal, and then when you get into international disasters, it becomes even more complex.
So I will say that, as for all humanitarian emergencies, the, command and control rests with the local government. And so the government of Liberia has its incident management system, and then that brings together all of the different players. And so the incident management meetings occur, pretty much weekly, and they include representatives from the government ministries and then also from the different NGOs such as International Medical Corps, Save the Children, MSF that are involved in the response, and then also the UN agencies like WFP, WHO, et cetera. It was a very unique situation because of the fact that it's an epidemic and not a disaster or a complex emergency, and also because of the fact that the UN system already had ongoing emergencies in Syria and Central African Republic and in Iraq that were already stretching the humanitarian system even before the epidemic started. So I think there was a bit of a delay in really activating the UN coordination system, the cluster system that would usually be activated quickly in a humanitarian emergency. I think that perhaps the biggest problem in this epidemic has not been so much one of coordination. Of course, that's always an issue. In Haiti, you had thousands, literally, of NGOs responding, and you had a huge coordination nightmare. Here in Liberia and in Sierra Leone, the bigger problem has just been very few responding organizations, and so coordination has been really a secondary problem to the bigger problem of just not enough actors on the ground. So this is somewhat unique in terms of humanitarian emergencies in that way, because usually it really is coordination that's the biggest problem.
Thank you, Adam. And Dr. Omaswa, if you could give me one moment. Dr. Cameron is leaving, but she has one question or so, or a comment.
Yeah.
And then
Thank you so much. I actually just wanted to do a quick two-finger response on that question, because I think the question that you asked about command and control is a critical one, and I agree with everything that all of the speakers have said. But I will say that command and control in Liberia and Sierra Leone, and also looking at Guinea and now in Mali, has come out as one of the critical functions for this unique type of situation, because the command and control function and the logistics function is unique, and it also requires a very well functioning public health emergency operations center and command and control and incident management system that can go out and actually link with epidemiology and conduct the contact tracing necessary and the lab confirmation. I mean, it's just a lot more complex. The U.S. and what's been done with DOD and with USAID, working closely with all of the NGOs that are on the ground, and I totally agree with Adam that the situation here was a situation where there just weren't a lot of organizations with this kind of experience to be able to respond. The U.S. in Liberia, working very closely with the government of Liberia, and the UK and Sierra Leone have been able to take on actually a portion of that command and control function and transition it with the host governments. In Guinea, that's starting to happen, but there's still some needs in Guinea, in my view, and also in other, potentially if Mali were to become a bigger situation. So I definitely would encourage thought about the public-private partnerships and the logistics partnerships necessary to be able to plug in. I think that it's going to be, we're making a lot of progress, and there's definitely bright spots out there, but it's going to be a long haul before the epidemic is ended. So I strongly encourage consideration to emergency operations center capacity in other countries in West Africa, making sure that the preparedness that needs to be in place to prevent spread and to prevent what's happened in the 3 affected countries would definitely be a place where I would encourage public-private partnerships and the communities that you work in to focus more on. And thank you very much for the opportunity. I'm sorry I have to go.
thank you, Beth. Dr. Omaswa, please.
I want to congratulate the presenters for sharing their very exciting experience with us. I don't really know where to start my contribution to this conversation. Maybe just to say that I am from Uganda, as you heard yesterday. Up till this current outbreak in the 3 or 4 West African countries, Uganda held the record of having treated 425 cases in an epidemic in the year 2000 in northern Uganda and 2 other districts. And at that time, I was the head of the medical services in the country. So we have that experience, which I think we have shared through publications as well as through more recent blogs, and we published in the Lancet and so on, at least what we learned at that time. At the moment, I'm also contributing. I'm part of the African Union group who are working to get on top of the epidemic. So what would be, very briefly, my messages to you, the American public-private group? One, the root cause of the problem, the way it has gone, is weak health systems in those 3 countries. And weak health systems really means being able to reach households, being able to win the trust of the local people by the public health system, and also the partners who go in there. And in this case, we are given to understand that from the beginning, the local population did not even believe that there was a disease called Ebola. Where has it been all this time? This is just a trick to make money from, to make money by the government and other people. So building strong health systems, primary health care systems in the countries is critical. Perhaps it's the most important thing that we should do. Also, the response to that epidemic. We've been told about building hospitals, all that logistics by the Army, UPS, all that is very good. But stopping new infections should be really where our effort should be. And stopping new infections takes place in the communities, at the households. And my suggestion to you is that when you give your resources or when you give advice to, let's get community health systems that are going to be able to identify cases, hand them over to the health system for testing, etc., etc., etc. But not enough is being talked about that. Not only for the countries where the epidemic is now, but also for other countries likely to get the disease. Then I think the third one now is that Ebola now is in that area. We hopefully will be able to control this epidemic, this outbreak, I don't know when, but there will be other outbreaks sooner or later in those very countries and maybe also in the neighboring countries. So quick, let's get the systems to get all the countries, quite literally all the countries in Africa, to prepare for Ebola. And preparing for Ebola is about strengthening, I think Adam talked about surveillance systems. Yes, surveillance systems are also only just part of the comprehensive primary health care systems. And what a primary health care system is, what it should be is known, so it's not really something we should talk about. Then a command and control, Patrick Kelly. Well, I've heard that it's not been an issue. But I hear that it is actually a big issue in this West African situation. I was at an African health ministers meeting just 3 weeks ago on this topic in Benin. And what we were told is that not everyone follows what the government of those countries actually wants to happen. The messages which are issued, maybe the government should issue the message, but some other entities are issuing statements on the disease situation outside the command structure. So I think it may be argued that it's not as it may not be entirely correct to say that the command structure is working. And it's part of the challenges of the control, of the epidemic control. I shouldn't speak very much. Let me just give you briefly what we were told by the African Union 3 weeks ago and what I see from the email exchanges going on now. The UN Secretary General, this is now the Global Command and Control. It's been established UNIMIL, and that is got a sub-headquarters in Accra, in Ghana. And the African Union also has established a structure which has got also soldiers there. It's actually led by a Ugandan Major General. And the World Bank and the UN Secretary General chiefs were in Addis Ababa, I think 3 weeks ago. And the plan which we are told moving forward into the future sustainable is that money will now be given to the African Union structure to recruit additional health workers who are needed in moving into the long term. And African countries have been asked to recruit health workers through the African Union system. And when we were in Benin, very many countries volunteered to provide health workers. Also, 5 countries offered for infected patients to be transferred to their countries. They have got some treatment facilities there because that's also a big political issue. There are countries abroad in Europe and maybe even here who are willing to take like health workers who are infected, but their local populations don't like the idea of bringing Ebola home. So Africans have been told you should treat your own patients. So 5 countries offered to accept infected persons, provided that the treatment facilities are given. So it's a long story. In just a summary, primary healthcare systems in the countries is very, very important, which are led by local people. And then 2, I think it is now, we need money. And if the monies could be put together through those either UNIMER or the African Union system, that would be a way of getting on a long-term basis more health workers to go and treat those who are infected. But also we need money to get the communities to be able to police themselves and stop new infections from taking place. So there is plenty of room as we move forward for additional resources in those affected countries and in other countries too. And somehow we should find a way of joining UNIMER and the AU group to get a system going in the next few months and into the future. Spoken too long, I think. But.
No, well spoken. Thank you so much. I hear very sincerely what you're saying. Thank you. Could you identify yourself?
Louise Flynn from Ecology and Environment, and a lot of what I was going to say has been said. So I just wanted to bring up the private partnerships where we haven't been talking about private organizations. There are many multinationals working in these countries, as brought up with the example of Firestone. There is an Ebola task force among the mines that are in these countries and surrounding it. There also, any of these mines, any of the oil and gas facilities are working with organizations such as ISOS, who also has Ebola task force. Within Uganda, we've through the Respond project that was there, we've actually started training within the private sector, peer educators about Ebola. So I haven't heard a whole lot about the private sector within those countries. I think there should be further discussion on that. And that is also where you can get the prevention. I was wondering if there's any prevention that's going on with the training by DOD, because the message has to get out to be able to ensure, and it has to be gotten out at the very local levels to be able to ensure that this doesn't spread. And for other communicable diseases, because if there is a structure in place, then the message doesn't only have to be for Ebola, because there are many different other issues that have to be addressed in these countries.
I just want to comment that the department has a fairly aggressive global health engagement program, and the focus is very much on trying to, I will say, strengthen the public health systems of the countries in which we are combining. We're working with the Ministry of Health or the Ministry of Defense, depending upon what the country that it is. But the focus has got to be in getting information down to, training to, and experience for those individuals who are providing the public health support within the countries. Because you're absolutely right. We can't do this from outside every time. It's got to be done by the countries themselves, by strengthening them from within. So.
I see two more questions. John and then Wendy.
Thank you very much. My question is really for Larry. We're here focusing on public-private partnerships, but I'm actually interested in the public-public partnership, and that is the civilian and the military side of things. I was at the U.S. mission to the UN in Geneva in July 1994 when 800,000 Rwandan refugees crossed the border into eastern Zaire, and President Clinton sent in the U.S. military to support the UN High Commissioner for Refugees. But the military focus was on its tasks, its specific mission, and as soon as those tasks were met, it wanted to leave eastern Zaire and that support operation. And the civilian side kept saying, well, but look at all the needs, look at all these humanitarian needs, and wanted people to, wanted DOD to continue the support. This made the front page news in the Washington Post at one point, this kind of controversy. Here, we've been talking not just in this session, but in previous sessions about the need for strengthening health systems. And it is so clear that in the long term, one has to strengthen the health systems in these three countries. And that's, in a sense, from a civilian perspective. But I'm curious what you see as DOD's continuing role here. Is the sense at the Pentagon that as soon as we finish these tasks, we're done, we got to worry about Syria and Ukraine and ISIS? Or is there any sense there that some of this longer-term needs will affect U.S. security and global health security, and we need to stay on?
The ambassador is very perceptive. Yeah, the tasking we have was to provide an interim capability. The mission to combat Ebola is not a primary mission of the department. The battle against ISIS is. And so there is that issue of how long will we continue to support Ebola, the fight against Ebola. The intention originally, as it was laid out to us, was an interim capability until the other organizations can develop their capability to step in and take over for us. So that's really the marching orders we have at the moment. Now the question really comes down to, are we talking in 4 months, 8 months, 2 years? Don't know what that number is. It'll be until the leadership in not the DOD perhaps, but in the nation. What the president decides we have done enough and we'll move on to. It'll also depend on how well the CDC can ramp up its public health course to take over some of the things that we are doing. And certainly once we have built the treatment facilities, unless they also ask us to do the same thing in Sierra Leone or other countries as necessary, we'll take those on if and when tasked. But right now it's an interim capability.
Wendy? I think this will be the last question, and then we'll close.
Great, and I'll be quick. So this is perhaps a bit of a comment and food for thought, but also perhaps a question for Adam. So one of the things we haven't talked about is kind of a secondary victim of the Ebola, outbreak, which is really the total collapse of routine health services in these affected countries. And so we in Liberia, measles vaccination rates were 96% before the outbreak. They're now down to 25%. So any measles outbreak could have a devastating impact on child mortality, case fatality rate of 30% for measles. There's virtually no obstetric services. There are some being provided in some areas, but it's primary to wealthy populations, and virtually no C-sections. So we certainly are going to see an impact on maternal mortality rates as well as infant mortality rates. So as the priority has shifted, and I think rightly so, toward actually stopping this Ebola outbreak, is there a role that the private sector could be playing to try to help underpin just even the routine health services so that this sort of secondary effect of this outbreak is not going to continue to be one that's very, very difficult to recover from? So Adam, I don't know if you have any thoughts on that based on your personal views that you've seen.
I do. I mean, when I arrived in Bond County, all 3 hospitals in the county were shut down. All public health clinics were shut down. There were a couple private clinics that were operational, but not even very. There were no deliveries going on in the entire county. There were no vaccinations going on in the entire county. There was no nutritional screening. And that's, really why I say that this is a virus not of individuals, but of health systems. And as a result, all of global health depends on eliminating this virus. The problem with working on, getting healthcare systems up and running is that it's really tied to control of Ebola and control of the epidemic. So I'll give you the example. In Bond County, the main government hospital is Phoebe Hospital, and it had shut down back in July when 7 of its nurses became infected and 6 of them died. And the staff at the hospital were unwilling to come back to work until we had opened up our Ebola treatment unit. And once we had opened up our Ebola treatment unit, and we set up a very close relationship with Phoebe Hospital, where any suspect patient that they were even the least bit concerned about, we would immediately send our ambulance to pick up and take to our Ebola treatment unit. It was only after that that the nurses and doctors and other health staff were willing to go back to work. The problem is that right now in Liberia, it's routine health care that's by far the most dangerous thing you can do as a health professional. Working in the ETU, you have full PPE, you're completely protected. The risk of contracting Ebola is very low. Working in a regular government hospital or clinic, you're seeing patients with undifferentiated symptoms, and you don't have full PPE for all of those patients, and so your chance of getting infected with Ebola is actually very high. And so really, no one is willing to work in the system until you have containment of the Ebola virus, until you have systems in place for rapidly triaging patients and quarantining them, isolating them in facilities. So I think that in order to get the healthcare system up and running again in Liberia, that really does require getting the Ebola epidemic under control first.
Thank you, and I'd like to thank my panel very, very much, and also the forum for helping us mobilize this terrific panel. Thank you.
Thanks, Louise, for organizing it. Yeah, thank you very much. Okay, we have a lot to think about. I'm going to violate the norm a bit from the schedule and say let's come back at 1:30. We will end at 3 as promised, but I think people could use a stretch and a sort of some fresh air and a timely consumption of your boxed lunch so you don't get too excited about get too big a lunch and not able to think and talk and engage. And we'll come back promptly at 1:30 and really begin the final session. We sort of pull it together, and especially picking up on these themes, what are the priorities for our work going forward? We've heard a lot of suggestions and candidates. We really need to get a bit of a game plan here. So thank you very much. Thank you all very much for coming.